Hello, everybody, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Deborah Foreman, the Educational Programs Coordinator for MS Focus, and I'm joined today by Dr. Aaron Boster, who's going to answer as many questions that you have about MS in the next 60 minutes. I'm delighted to introduce him. Dr. Boster is a board-certified neurologist specializing in multiple sclerosis and related central nervous system inflammatory disorders. He decided to become a multiple sclerosis doctor at age 12 as he watched his uncle Mark suffer from the disease in an era before MS treatment was available. Dr. Boster grew up in Columbus, Ohio, and attended undergraduate school at Oberlin College. He earned his MD at the University of Cincinnati College of Medicine and completed an internal medicine and residency in neurology in clinical at the University of Michigan. He then completed a 2-year fellowship in clinical neuroimmunology at Wayne State University. Since then, Dr. Boster has been intimately involved in the care of people impacted by multiple sclerosis. He has been a principal investigator in numerous clinical trials, trained numerous multiple sclerosis doctors and nurse practitioners, and provided and published rather extensively in medical journals. He lectures to MS patients and provides worldwide with a mission to educate, energize, and empower people impacted by multiple sclerosis. He lives in Ohio with his son Maxwell. And Dr. Boster, we're really pleased to have you. And normally I would not read that long of a bio, but I love it. So every single time I read it, because you never know, there might be somebody coming today that has not heard that before. So anyway, we're very pleased to have you. Give me 2 seconds just to let everybody know that has not come how we're going to do the Q&A, okay? If you have a question or comment, you can simply ask it by the Q&A button in the app, which also allows you to send your questions anonymously if you choose. You can even ask your question live by raising your hand, and to do so, you just click on the raise hand button or press the *9 if you're on your phone. I'll call on you, and of course, at that time, you'd have to unmute to ask your question. So I'm going to go ahead and turn it over to you, Dr. Boster.
Thank you so much.
Yep. Actually, let's do this. I'm going to lower this. I'm going to go ahead and, although I'm turning it over to you, I'm changing that. I'm going to do our very first question before I take anybody else's, okay?
Perfect.
And this is coming from Maritza, who is 46 years old from Pretoria, South Africa. Mm-hmm. And I don't know if she's attending, but if she is tonight, I'm so glad you're joining us. So she was diagnosed in April of 2024 with relapse remitting MS. She's on Bonspree DMT, and she said she has double vision in November. She's had double vision since November of 23. And at that stage, she did know that she had MS. Mm-hmm. So this is something that came in, by the way, through email. And everybody can do that if you'd like in advance. You can send an email and we can read it for you. So she said she had a huge attack at the end of March where her right leg was dropping, bad handwriting, very poor balance, and vertigo. And also she was in the middle of menopause. So she has some questions. And the first one is that her headache is not normal, doesn't feel normal. It literally feels like it is inside her scalp where the lesions are. And she wants to know, why is this?
So first of all, thank you for feeling comfortable writing in. This is a relatively new diagnosis. With someone who was just diagnosed in April, it's very, very fresh. As I'm counseling and helping families impacted by MS, I'm very, very quick to remind everyone, it takes about 2 years before you feel comfortable with the disease. I don't mean intellectually, I mean like emotionally, where you can look in the mirror and say, I'm going to be okay. And so this is well under 2 years. And I can only imagine that this very nice South African is struggling to make sense of the world. Now, the first question is, hey, I have these headaches and they're pretty significant. The actual tissue of the brain can't sense things. Like there's no sensation inside the brain, but the coverings of the brain are exquisitely pain sensitive. And it stands to reason people impacted by MS are twice as likely to experience headaches compared to the general population. The one good thing that I want to convey is treating headaches is not hard. Neurologists are pretty darn good at it, generally speaking. You have nothing more than to bring to the attention of your neurologist, hey, I got a wicked headache, and there are a host of things that can be done to thwart it. This is in the category of symptomatic management. So we're not going to use a disease modifying therapy, which slows down your MS to treat your headaches. We're going to treat those separately. But it's such an important aspect of quality of life that I implore you to talk to your neurologist, and they'll serve up a host of options to make it better.
Thank you. She also gets a lot of inflammation in her throat, and she can swallow, but however, she struggles with pills. So she always feels like something's stuck. She wants to know about that.
The Scrabble word for that is called a globus sensation, when we feel like there's a lump in our throat. It's hard to swallow. So swallowing is a very, very important function. And when we think about the way that someone with MS can get themselves in harm's way, one way is a decubitus ulcer, like a bed sore. One is urinary retention, which can seed the blood and cause a urosepsis. Three is swallowing down the wrong tube. So when someone tells me that they're having difficulties with swallowing, I think it's really important to take that seriously, excuse me. So what can we do about it? If there's truly a big concern on the table, we send them to see a speech pathologist. So these are wizards that are cousins of physical therapists and occupational therapists, and they are masters of swallowing. And they can figure out if, in fact, there's a problem with swallowing, at what level it's at, and then what compensatory maneuver can make it safe. In the short term, what I would recommend, because I imagine, like many of us, we take pills every day, is that you don't take pills while doing other tasks. So we're not going to drive and take a pill, or talk and take a pill. We're going to be very focused on the pill, put the pill in the mouth, and then follow it with a bunch of water and swallow copiously and try to get that pill down. Sometimes by focusing on it and by really using a tremendous amount of water, we can help make that more easily obtainable.
Perfect. After cleaning the house or even being out shopping for about an hour, her right leg starts limping. She knows it's body heat. Is this going to get better over time?
So a very, very common phenomenon of heat sensitive symptoms. And what presumably has happened, if we listen to the woman's story, she suffered an attack where her leg got weak and it recovered, but it didn't recover 100%. It recovered, let's say, like 93%. So now when she exerts herself and gets overheated, she short circuits the damage, and then the leg is weak again. The first thing that I want you to know is you can't make it worse by overheating your body. Some people become scared, oh my gosh, if I do too much housework, or if I go outside or whatever, then I'm going to make my body worse. You can't make it worse. All you're doing is uncovering old damage, and as soon as your body cools down, you're good in the hood. All right, so there's no permanent damage to the body. That's important to know so that you don't live in fear, oh my gosh, if I heat myself up. Now, the second thing that I want you to know is that's treatable. We can treat that. There's two ways that we typically treat it. One is by cooling the body, like wearing a cooling vest or a cooling kerchief or things like that. The second way that we do it is with medicine. And there's actually a medicine in Europe, it's called Fampyra. I'm not sure of the brand in South Africa. 4-aminopyridine, or Ampyra, is the drug that we're talking about. And it only works in about half to a third of people who try it. But when it works, you're taking a pill twice a day, it buttresses against heat sensitivity. So you get overheated and your leg doesn't get weak. Now, the question was actually, is it going to get worse? And there's no reason to assume that it will intensify. What's happened is you've had an attack and you have not made a 100% recovery, and you have accrued a little bit of disability. And so now we have a chronic symptom, which is going to plague us if we get overheated. So we want to game out how to improve upon that. Wearing a cooling vest while you do your household work is a great tool. Taking Ampyra is a great tool.
I love cooling vests.
Me too.
I love cooling vests, and I don't even have MS. I love cooling vests. Before Bonspry, did I pronounce it correctly, Bonspry? Before Bonspry, she would feel like she was sitting on a swing going back and forth. This improved a lot with the Bonspry. Will the drunk walking get better over time?
So it's it's very confusing early on in the diagnosis, trying to figure out all the different things. So obviously, I have never met this person and I haven't examined them, and so I'm making some inferences. But what I imagine happened is you suffered your first significant attack, and an attack doesn't go away the moment you take a steroid. It can resolve over a little bit of time, and while it was resolving, you started your disease modifying therapy. It's possible that the disease modifying therapy dampened some of the symptoms, but that's not a foregone conclusion. And I want to separate for us medicines to slow MS down from medicines that treat chronic symptoms. So Bonspree, which is ufatumumab, so in the United States, the brand is Kesimpta. It's a B cell depleter, is a highly effective medicine, very, very good at preventing attacks, very, very good at stopping new spots on the MRI. It can slow down disability and slow brain volume loss and all the things. We don't take the medicine to prevent the symptoms or to treat chronic symptoms. Sometimes we have to use that medicine, and then in addition, we have to do things to help with the balance. Now, to talk about balance for a second, there's unfortunately no pill for balance. I wish there was, that would be awesome, but that doesn't exist. The treatment for balance is neurophysical therapy. And so if you're still having some unsteadiness of gait, I implore you, you need to go see a neurophysical therapist, and they will help you optimize your gait mechanics and prevent you from falling and get you to walk much more safely. You're going to do that along with the ufatumumab.
Perfect, thank you. She knows that bladder problems in MS are there, and menopause, those urinary things with that also are
Yep.
hand in hand. She's tested for a urinary infection and there's no infection, but she goes to the bathroom 3, 4 times a night. Can you talk about that just a little bit?
Yes. So, unfortunately, the down theres can be affected in MS frequently. And the down theres, bowel, bladder, bedroom. And so, when there's spinal cord damage causing your leg to be weak, it can also impact the circuitry of your bladder. And then what can happen is the bladder, which is a bag that holds urine, can contract down to the size of a racquetball. So now you drink half a soda and then it's full and you got to sprint to the bathroom and you have what's called overactive bladder. Overactive bladder manifests one of three ways typically. We either have urgency, which is, oh my God, move or I'm going to pee, or frequency, I know I just went, but I got to go again, or nocturia, which is what this woman is describing. Nocturia is a situation where you're getting up multiple times a night to go pee pee. Now, there are ways of combating nocturia. One behavioral way, which I recommend, is to consume 2/3 of all the liquid you're going to drink during the day in the first half of your day, which means you are really hitting the water hard breakfast, just after breakfast, before lunch, during lunch. And then you slow down and you want to stop liquids at dinner. So if you have a presumed 6 p.m. dinner, you're going to stop drinking liquids after 6 p.m. Now, if you have evening pills to take, go ahead and have a sip of water. I don't want you walking around the house going, go ahead and have a little sip. But we don't want you bringing water to the bedside table because you make urine for 6 hours after you drink something. So if you're drinking fluids until 11 p.m. when you go to bed, 1, 2, 3, 4, 5, 6, you're making urine till 6 in the morning. If you instead stop drinking fluids around 6 and go to bed at 11, you're really not making a lot of urine and you're going to cut down on the number of times you have to go to the bathroom. Now, there's also medicines which are very effective at helping expand the bladder to a normal size so that you don't have to rush to the bathroom, so you don't have frequency, and so you don't have to pee so much at night. So this is another situation where we can use a pill for that ill, take a medicine once or twice a day, and it will cut down on those bladder problems substantially.
Thank you. And you know what? There's more, but Maritza will try to get to them a little bit later. And if not, we
Absolutely.
can always send them to you or to Sherry Binns, our MS nurse, and we can get some answers from that also. So
Perfect.
let's go to our chat where, let's see, Lillian says, so glad to be here. Can MS cause muscle weakness to the lungs and diaphragm?
So that's a very, very good question. So, generally speaking, the lungs do not take a direct hit when dealing with multiple sclerosis, but the muscles of the rib cage can sometimes take a hit. And so it's very rare that we have like primary lung problems, but there can be difficulties in opening the bellows. There's a device which you can buy on Amazon for like no dollars called an incentive spirometer. Okay. And if you've ever been in the hospital, they put them on your hospital bed. It's like a little tube with a suction that you suck on. And what it does, it gets the lungs to pop open. And so there are patients that have some difficulties with shortness of breath and with lung function. I will have them use an incentive spirometer about once an hour all the time that they're awake. And that can help a whole lot. If we need to, we can do special testing to look at the function of the lung. But fortunately, it's normally not directly affected.
Thank you. Michael's asking, are there any new infusion meds besides the three that are out there?
Well, let's see. So I don't know where he is or which ones he's talking about. So let me just list some infusions and we'll count them. Okay. So there's Tysabri, which is natalizumab. That's an infusion taken once a month or once every 6 weeks. There's alemtuzumab, Lemtrada, all right, which is given for 5 days and 3 days, then no more. There is Ocrevus, which is a B cell depleter taken twice a year. There is Briumvi, which is a different B cell depleter taken twice a year. There is rituximab, which is another B cell depleter taken twice a year. There's Truxima, which is another B cell depleter taken twice a year. So those are all infusions. We also have I'm trying to think if I'm missing any infusions. Those are the ones that are on label or available. Sometimes we also use IVIG, which is an infusion. Those are all the ones that I know about. Now, at the Boster Center for MS, we're testing a new infusion, but it's still in research, and it's called Frexa. And so Frex is a really exciting anti-CD40 ligand. I didn't make up that term. And it's in MS research right now. And so we are actively enrolling patients to receive Frexa, which is an infusion that's given about once a month.
Right. Jen says that she's 47 years old, American living in Egypt. Wow. Brother has MS, talked to you once before. 2 years ago, started with ascending numbness bilaterally up to the waist, dysphagia and imbalance, also numbness in distal wrists and palms bilaterally. Had 2 lumbar punctures and IgG index, both negative. 2 brain MRIs showing multiple lesions in MS, like pattern, including in pons. Whole spine MRI showing, showing lesions, bone marrow, edema, and multiple bulging discs. EMG/NC show no signal in perineal and sural nerves. Bilaterally, mild motor dysfunction, underwent plasmapheresis and IV solomedrol, no effect, improvement. Docs now say no MS because of above and no optic neuritis, nystagmus and age of onset. They are calling it neuromyelitis, taking gabapentin and tizanidine doesn't help much. Neuropathy down to 610 from 810. Cold water helps somewhat. Could this be CIDP or systematic sclerosis without cutaneous lesions? And would the treatment be rituximab, too slow, stop progression? What else to take for severe muscle tightness, burning, spasms? And she says, thank you.
So first of all, that's a lot going on in that poor person. Very, very serious disease. If I were to summarize, they have a problem with the spinal cord. All right. So this ascending numbness and weakness business, the difficulty with the swallowing, all of these scream spinal cord. So there's some type of problem with the spinal cord. Now, when they do MRIs, they see that the spinal cord is swollen. which further supports the idea that there's a spinal cord problem. When they do EMGs, they don't look terribly abnormal, again, pointing at the spinal cord, not the peripheral or the peripheral nervous system. So we have an inflammatory spinal cord problem. And it doesn't sound like it fits the bill exactly for MS. And so it may very well be a cousin of multiple sclerosis. I don't think that we need to look much farther than neuromyelitis optica spectrum disorder or MOG, which are mimics of MS and can present with wicked spinal cord problems like this. And the drug that was mentioned, rituximab, is an outstanding drug to treat that problem. So when we have spinal cord inflammation, even if we're not sure of the name of it, I always turn to medicines like rituximab, and I most absolutely would consider using that. I think in addition to quelling the inflammation and providing immunosuppression to calm down the spinal cord, we also want to use therapies to help with the spasticity, which is a spinal cord symptom. And so there's a host of things that can be done. Obviously, without seeing the person, it's really hard to weigh in, but we would start with oral medicines like baclofen. We might use some focal toxins like Botox for particular areas of spasticity. And depending on the severity, this person might benefit from an intrathecal baclofen pump to provide adequate antispasmodic relief. So a lot going on. I wish them the very, very best of luck. And I think the Rituxan idea is spot on.
Thank you. Laura wants to know, would Veoza, which is used to treat hot flashes in menopause, help with heat sensitivity in MS?
So in full transparency, Laura, I don't know what that medicine is. And so I have to pass on the question because I'm not sure. Sorry.
Lisa says, my last Ocrevus infusion was February of 23, but my B cells level is still very, very low. How long does it take to repopulate?
So when you are young and healthy and you take a medicine like Ocrevus or a medicine like rituximab or Briumvi, they deplete your adult B cells and then you make them back. And generally speaking, you're going to make them back between 6 and 12 months, like 6 to 9 months, probably on average. And keep in mind, please, we don't want them to come back. The goal of chronic B cell suppression is to keep them low, because if we keep them suppressed, then the B cells aren't available to get your T cells riled up to attack you. And so it's never my goal to wait until the cells return before I treat again. Unless there's a concern for infection, which there might be, unless there's a concern for infection, I want to give the dose every 6 months because I don't want to allow them to repopulate. I'm trying to keep them low on purpose.
Yeah, thank you. Do you, Deborah wants to know, do you think Ocrevus causes insomnia? And should my doctor be testing for JC virus titer level on regular basis?
Two separate important questions. So in my experience, Ocrevus does not cause insomnia. Now, when we give Ocrevus, we typically give a little bit of steroid beforehand. So that might cause insomnia, but just that evening, it shouldn't do it ongoing. Now, the person who wrote this is not a textbook, they're a human. And maybe for them, it does keep them up at night, but that's not something that I routinely hear about. The second thing I would say is the JC virus antibody test, which can be drawn, is not something that needs to be done, in my opinion, with a B cell depleter. So the risk of PML, which is the risk that we're talking about, with a B cell depleter is insanely low. It's very, very low. And so I do not routinely check JC virus titers when I'm treating someone with a B cell depleter. That's something that I do when I'm giving someone Tysabri, but not when I'm giving them Ocrevus.
Thank you. Justin says, smoking smokeless tobacco, is it bad? But what about nicotine gum?
So we know that smoking cigarettes increases the risk to develop MS by double, which is crazy. And we know that if you have MS and you smoke analog cigarettes, it can speed up your disease by upwards of 50%, which is also crazy, right? So smoking is maybe the very best way of speeding up your disease process. And of course, the flip side, not smoking is one of the best ways of slowing it back down. So the question is interesting because it's saying, well, what about just pure nicotine? And it's my understanding and opinion that the problem with smoking is taking a carbon-based material and lighting it on fire and then sucking the smoke into your lungs, which is very, very pro-inflammatory. And doing that is pro-inflammatory to the blood vessels, and it's pro-inflammatory to the lungs, but it's also pro-inflammatory to the brain, which is why we don't want you to do it. I'm not aware that nicotine gum causes the same kind of inflammation. And so if somebody was trying to quit smoking, I would feel very comfortable giving them nicotine supplementation, a nicotine patch, or nicotine gum as a way of transitioning away from analog cigarettes.
Thank you. Are there any new treatments besides Ocrevus for primary progressive MS? This is what Deanna's asking.
So, Deanna, we are studying several medicines right now. There's nothing that's FDA approved, but I'll tell you at the Boster Center, we're doing a trial called the Perseus trial, where we're studying a BTK molecule called telobrutinib, and that's being studied in PPMS. And I mentioned earlier the Frexa trial. This is being studied in progressive MS as well. So there's a lot of things coming down the pike that we're very excited about. But today, as we record this live stream, the only FDA approved therapy is Ocrevus.
Thank you. Tina wants to know if there's any medicines that can help improve walking. She took Impura for 3 months and it did nothing for her.
So it begs the question, what kind of problems are we having with walking? Um, because, having poor vision can impact walking. Not being able to feel your feet can impact walking. There's a host of things that can make you walk wonky. And I would suggest that the best way to thwart that is to get you to the physical therapist. Physical therapists are undervalued, underappreciated wizards that are really, really good at figuring out where the walking problem is and how they can improve upon it. And so if you take your walking to the physical therapist and let them assess you, they will develop a customized plan to deal with all the different component parts. And that works way better than any pill I've ever seen.
Thank you. Tina, here, I just lost it. 1 second. Let me go back. So Patrick said, can you say just a few words about the use of edible cannabis, THC, and and CBD, please?
Sure. So I think it would almost be impossible in the modern era to have a discussion about multiple sclerosis without also discussing ganja. And so thank you for being the one to bring that up. So I am a medical marijuana recommender in the great state of Ohio. I have been for many, many years. And I believe very firmly that cannabis can help with certain symptoms. So I'll start by saying that cannabis does not slow down the disease. So we don't use cannabis products to help slow down multiple sclerosis. It just treats certain symptoms. And it does not successfully treat, in my experience, it does not treat gait. It does not treat balance. It does not treat bladder. It does not treat cognition. And it does not treat depression, in my experience, having recommended cannabis to hundreds and hundreds of families. Where I do find it to be very useful is with neuropathic pain, it's outstanding. With spasticity, it's really, really outstanding. With insomnia, which is very common, it's outstanding. And I find that it can help a lot with anxiety. Now, there's one other unique area that cannabis helps with a lot, and this was taught to me by a patient. A dear patient of mine and I were talking about his cannabis use, and he said the biggest thing it helps with is uncomfortable situations. And I said, what? He said, well, as an example, when I ride my stationary bike, after about 20 minutes, his leg starts burning. And so he used to stop because his leg hurt. Now he will do an edible cannabis and then he'll ride his bike and his leg burns. He just doesn't care. And I said, well, you mean it doesn't burn anymore? He says, no, it burns plenty. I just don't care. And that allows him to do several hours worth of exercise, which is pretty slick. So there's lots of different ways of ingesting cannabis. And the way that I do not recommend is taking the carbon-based material and lighting it on fire and then sucking in the smoke for the same reason that I don't want you to smoke tobacco. There are other ways to get cannabis in your body, and the route of administration has everything to do with the goal. So, for example, if you have a sudden spasm, which wakes you from sleep, eating a gummy is not a good idea because it's going to take 20 to 45 minutes to kick in. So using a fast onset like a tincture or a vape pen can help you because those will kick in just minutes. Tincture is a liquid that you put under your tongue, and you've got giant blood vessels down there, which will absorb about 15% of it like right away. And then you swallow the rest, and it'll kick in about 45 minutes later, like an edible. A vape pen is a little pen looking device, and in it is liquid cannabinoid, like a liquid of the cannabis product. And when you activate it by pressing the button or sucking on it or however you activate it, it heats up that liquid below the level of burning. So it doesn't combust it. There's no smoke. It just heats it up enough that there's a vapor. Now, the vapor works very quickly when you breathe it in. It'll work almost as fast as an analog joint or blunt would, but we think it's probably much less inflammatory. And so by gaming out what you're trying to treat can help us decide how we dose it. I'll give you a different example, insomnia. So for insomnia, I'm a real big fan of people using edible cannabis, right? Another one is anxiety during the day. We can take a small dose of an edible cannabis to really knock down the anxiety. So it's not for everyone, but for some people, it's a really great tool to help them grapple with chronic symptoms.
Okay, thank you. Melissa says that when she exercises, she experiences Les Hermits
Lermite,
sign or even zaps. Does it create more inflammation to push through the pain?
so that's a great question. I really like that question. So when Melissa exercises and she moves her neck, she feels an electric jolt down her back and her feet. And that was named after a dead French guy named L'Hermite. Oh, c'est very nice. Because back then it was all the rage to like name stuff after yourself, right? Nowadays we don't do that. And unfortunately, Lermite's phenomenon is very common in people impacted by MS who have spinal cord involvement. And it's not going to make your disease worse moving your neck. So it's very important to me that you hear that. You can't damage your spinal cord moving your neck. And the reason that's important is because it feels like you can, because you go like this and it kind of electrocutes you. Now, the good news is it's actually not hard to treat Lermites. We can use medicines which were originally invented to treat seizures because seizure medicine stabilize cell membranes in the brain, and they'll stabilize the cell membranes in your spinal cord. So, for example, taking a medicine like oxcarbazepine or carbazepine twice a day, or even like a gabapentin can help prevent that. And so, depending on how bothersome that is, boy, I would like to treat that.
Thank you. And so Nita says, why does it hurt so bad? Her head hurts terribly when it rains, when there's thunderstorms. Is there any relationship to anything?
I don't have a nice answer, except when it's storming, the barometric pressure changes, and sometimes that can translate into a headache.
Mm.
Sometimes I feel like my patients have almost like a spidey sense. Like they'll say, "Hey, it's going to rain. I can feel it in my bones." And so it sounds like she has a spidey sense.
And Stephanie's saying, what is there anything that she can do to correct the myelin that's been damaged? Are there any supplements that can help?
No. Presently, we don't know a way of putting the myelin back on the sheath. There's a tremendous amount of research looking at remyelination. It's actually very, very complex. There isn't a diet which will serve up the pieces and parts to do that. Now, that's not to say that diet's not important, because diet's super important. And a diet which is a low inflammatory diet of quality foods can make a really big difference in managing your MS symptoms.
Thank you. Tom is newly diagnosed since June with relapse remitting, 63 years old. He's on Tecfidera, seems to be tolerating it well so far, interested in local support groups in Greenville, South Carolina. We can help you with that. Well, if you send an email to your reminder email telling us that that's where you live, Tom, I'll make sure that the person that does support groups for us gets back to you. Okay, we can do that. So let's go to Paula. Her toes have been really changed over the last year or two. They're starting to twist, and one her ankle is always swollen. She has been to physical therapy and does do exercises regularly. No change. She's 68 years old. MS is progressing. Can you please tell us if there's a relationship with the MS, the cause, and anything that she can do to better help it?
So again, I'm limited because I can't see your foot, Paula. But when I hear that the toes are twisting and that the ankle's twisting, it makes me think that you're having spasticity in your feet. Now, the good news is that's easy to treat. So, for example, we can Botox and we can make the toes stop doing that. And we do that at the Boster Center all the time. I'll have a patient whose toe pops up and it rubs on the top of their shoe, or when they put their foot down, their toes curl and it makes it hard to walk. And so we can make the toes relax and be normal. And we can do that with Botox. And the good news is that you do it, it takes 4 minutes and then it lasts for 3 to 4 months. And so then you can have a constant benefit without having to do something on a regular basis. So whereas I really am glad that you went to physical therapy and I'm bummed that it didn't help, that you might need to first have Botox to the feet and then go back to physical therapy so they can be more successful in helping you.
Thank you. Is Gilenya a good MS medication? Nina wants to know.
Yes, it's a good MS medication. It's not a great MS medication, and it's not a bad MS medication. It's a good MS medication. So Aaron's own personal opinion, all right, so this is just my opinion, I think it's a mid-tier drug. So when you look at Gilenya, Gilenya is very good at decreasing attacks and new lesions on the MRI. And it's pretty good at slowing brain volume loss. It's not awesome at progression of disability. So it'll slow progression of disability no better than like the first line interferons. So for me, I think it's a mid-tier medicine. So for example, if I was to use a car analogy, it's not a Honda Civic, which I happen to love Honda Civics, right? And it's not a Ferrari. It's like a mid-range Lexus.
And this person is asking, well, they said that they're a Medicare age and cannot find financial help for their DMT, which is not uncommon. They've tried various avenues to no avail. Do you have any advice?
Yeah, so there's a lot of different things that we can do. I actually, at the risk of sounding self-aggrandizing, I have a YouTube video on that topic, like how to get DMTs when you don't have access to like a lot of funds. So let me just share a couple options. So there's a drug out there called Aubagio, right, which is a branded MS drug. The generic name is teriflunomide. There's a different drug which was invented 100 years ago for arthritis called Arava, A-R-V-A-R, Arava, and its generic name is leflunomide. Now, when you take Arava and put it in your mouth, the first metabolite is Aubagio. And so Arava generic costs about 18 to 20 bucks a month, and with a good RX coupon. So when my patients are having challenges in accessing like DMTs, one of the things we do is we use generic off-label Arava. We use the GoodRx coupon and they pay like 20 bucks a month and their MS is treated. So that's an example. Another example is if you don't have insurance, then a lot of times a manufacturer will give you a drug for free, right? Another option is to consider a clinical trial. And there are clinical trials now. They're rare, but there are clinical trials which will go to 65. So that's a consideration. There's foundations which can help you cover medicines, but of the options I've listed, I am most excited for you to consider the Arava off-label, just because it's an easy drug to get a hold of and it's very inexpensive to take.
Thank you. Nicole has a question about how many lesions, does it matter how many lesions are on your MRI? And is it important to have a whole spine MRI? Is it important to know how many you have on your MRI?
So I think it's important to look at your MRI. I want you to see each MRI scan. I don't want your doctor to order an MRI and not show it to you, all right? Because I think it's one of the best ways of understanding your MS. So that's the first thing. Counting spots is not the best idea. So I don't encourage people to become spot counters because you can get really, really hung up on the number of spots, which is not the most relevant thing. As you can imagine, a spot that's this big and a spot that's this big are not the same animal, right? So not all spots are equal. What I care about very much is not the number of spots, but the delta, the change over time. Because if we've diagnosed you with MS and now we're following you, you're on a medicine and we're getting serial MRIs, the utilization of the MRI is really to see if the drug's working. So if you had 100 spots on a scan and the next year you still only have 100, I am very, very happy. If you had 3 spots and the next year you have 4, that's not okay. And so the delta is what I'm most interested in. Now, the next question is, should we have spine imaging? And I think spine imaging is important. So the consortium of MS centers recommends doing a brain MRI once a year and only doing a spine when there's new spine symptoms. And I only half agree with that. I think getting a brain once a year is a really good idea. I think getting a spine every couple of years is a best practice, because there are asymptomatic spine lesions. Now, when I say that, I'm talking about the cervical spine, so the spine that's in your neck. I like to get a thoracic spine when I meet someone as part of my full workup. And then I generally do not repeat the thoracic spine every single time or even every couple times. I do it very rarely unless there are new symptoms. The lumbar spine, I don't find value in ordering. So, in summary, I would get a brain every year and I'd get a cervical spine every couple years, and I don't get a thoracic spine very often at all.
Thank you. Charlie says their MS was diagnosed at 43 and then it went away, just and then reappeared last year. The MS doctor said at 60 that they're too old. What can they do to treat their MS now?
So, I will refrain from saying sassy, inappropriate words about that MS doctor, but I very much disagree with that MS doctor. And that's about as polite as I can pull off, Deb. So MS doesn't go away. The reason that we inappropriately call it relapsing remitting MS was because we didn't fully understand back in the day when it was first described. Because someone will clinically have an event, an attack, and then they'll have a period of time where they're not having an attack. And then they'll have another attack, right? So we inappropriately referred to that space in between attacks as remission, which it is not. So we borrowed the term relapsing remitting from a different disease, cancer. In cancer, God forbid your cancer returns, you've had a relapse of your cancer. And then when they treat it, you're in remission. And we borrowed those terms in MS inappropriately because when you're not having an attack, the disease is still very active, I assure you. And I can prove that to you by getting serial cognitive testing, by looking at the rate that your brain shrinks at, and by looking at new spots on the MRI. You're having disease, it's just not manifesting clinically at that time. Now, what I would do about that doctor is I would fire the doctor and I would find a better doctor. All right. Because 63 is not old, sir. And you still have an immune system which is attacking you, obviously. And it's active because you just had an event. And you have a nervous system with features that you like smelling and hearing and chewing and having an orgasm and wiggling your fingers and thumbs and stuff. So these are all features that you want to maintain. So I want you on a medicine. And if your doctor doesn't have the foresight to do that, get a different, better doctor.
Thank you. Teresa wants to know, should a person with MS consider back surgery? She has 2 discs, 4 and 5 on top of each other, pain, tightness, fatigue, and can hardly stand at times. So
Yes,
she doesn't know if
yes,
she
yes,
should do it.
yes, 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 yes. In fact, when we have someone who has a disc that's pushing on their back, it makes it harder for the MS neurologist because now, if you have a new leg problem, it's one of 2 reasons. It's either the back problem or the MS. If you have the surgeon pluck out the discs and fuse the bones, that's no longer a possibility. Now, if your leg's a problem, I know why. So it's safe for people with MS to have surgeries. You're not a fragile China doll. You won't explode. And you can recover from a surgery very, very well. So I absolutely would get ye to the surgeon. Yes.
Thank you. And there's somebody who said they're recently prescribed modafinil. Is this an effective treatment for MS fatigue?
Very. So modafinil, the trade name in the United States is Provigil, or armodafinil, trade name Nuvigil, or stimulant medicines like Adderall, Ritalin, Vyvanse. These are very, very transformative for my patients in helping them stay awake and be more attentive to remember better. And so I always remind patients we give Provigil to airline pilots when they fly across the Atlantic to keep them sharp and awake. When you give a chess grandmaster Provigil, they win more games. This has been studied. And when you give someone impacted by MS Provigil, they're able to stay awake and they're able to attend better, which makes them have improved cognition. So I am a big proponent of using stimulant medicines when safe to help people live their best life despite having MS.
Thank you. And can you suggest the best exercises for helping people with neuroplasticity?
Yeah. So I guess if I was going to give a shout out for working on neuroplasticity, I would first recommend that you reach out to Gretchen Howley. So Dr. Howley is a physical therapist, and she has started a amazing, amazing movement called Missing Link, MS Link, right? Yeah, like so Missing Link. She has an online presence. She is a PhD physical therapist par excellence, and she has tremendous suggestions for neuroplasticity. She's written a beautiful book, which I have in every one of my clinic rooms. She has a YouTube channel where she talks about neuroplasticity and exercises for it. And she even has like classes that people can take. So she doesn't pay me. I just think she's amazing. So that's why I said all that. And so, what are some things that you can do to help with neuroplasticity? So, any activity that you can practice, you can train via neuroplasticity. So, for example, if you're having trouble walking, you can relearn to walk. And while you're relearning the movements, your brain is rewiring. Okay. So, don't let someone tell you that you're too old for neuroplasticity. It's simply not true. And through proper repetition and practice, you can retrain those pathways. But if you're not familiar with Dr. Howley, check out Gretchen Howley, MS Link. It's amazing. Good stuff.
Thank you. And Denise wants to know, why is spasticity worse in the evening?
Spasticity is worse under two conditions. Number one, when you're still. Number two, when it's cold outside. So presumably you're running around all day long, working and managing your household and all the things. And then at night, it's finally time to relax. The kids are finally in bed and, it's finally quiet. So you sit down and relax. And as you rest, your legs become tighter and tighter. It's very common that we see worsening spasticity in the evening hours or in bed or upon waking. And it's very likely because you're still.
Hmm. Okay. This person was diagnosed back in 2000, February of 24. When diagnosed, the doctor found 20 lesions. MRI was done in 2D medicine, and they just completed their second half of Ocrevus in May. Again, they did another MRI, but this time 3D, and found out 58 lesions. Is it possible to get almost 38 lesions within 5 months?
Um, there's not enough information for me to answer intelligently. I would have to look at the quality and the technique for acquisition of the imaging before I could really answer that question. Is it common? Absolutely not. Is it more likely that the quality of the MRI will enable them to see more? Yes. But I don't have enough information to answer beyond that. I'm sorry.
Okay, thank you. And Susan says, should she have PT prior to using a walking aid? Falls, broken shoulder, etc. Balance is off sporadically, heat intolerance, and neuro recommended Mavenclad or Briumvi. I am looking at Tysabri, 57, so I'm too old to start fourth DMT.
So that's 8 questions, all crammed into one. And so the first thing I would say is yes to the physical therapy, right? So independent from whether you get a walk aid or not, you're going to benefit from physical therapy, sharing what you just told me, right? So I would start with physical therapy, and then I would ask the therapist, what assist devices do you think would be the most useful? Do you think a walk aid, for example, would help me? And the physical therapist will be very, very well positioned to answer that question. The other question, the gal is raising several different DMTs, and I don't have enough information about her as an individual. I can tell you that those are all very good medicines, but we have to kind of match her specific situation up to those meds, and I can't do that without more info.
Thank you. I find this very interesting, actually. Somebody's learned, Debbie learned, that the nerves that control blood pressure, breathing, heart beating, etc., are not affected by MS. Can you help her understand why that is?
So those nerves are part of the autonomic nervous system, right? So the autonomic nervous system is what helps keep your heart beating and all those kind of things. And that's part of the peripheral nervous system. So in the body, we neurologists, because we're super nerdy, we divide things up, right? So we think about the central nervous system and the peripheral nervous system. So the central nervous system is brain, optic nerves, and spinal cord, like all the stuff that we think about in the setting of MS. The peripheral nervous system, which includes the autonomic nervous system, is separate from that. Now, what she's saying is not 100% true, because if you damage parts of the brain stem, it can rarely have an impact on the autonomic nervous system. But generally speaking, that's not the situation, and it's extremely rare. I've never seen it where the MS affects the heart in that manner.
Thank you. Teresa said that she's 30 years old with relapse remitting, diagnosed November of 22. She's pursuing pregnancy via IVF in the near future. In the past 2 months, she's moved from Detroit to Chicago, which led to a change in neurologist. I have been on Tysabri since diagnosis, but my new neurologist wants me to change to Ocrevus. I've tolerated Tysabri well, and I'm concerned I may not respond as well to this new drug. He feels Ocrevus is safer for pregnancy. Would you agree?
I would agree based on the French data. So let me talk about this a little bit. So at the risk of dating myself, back in the ancient days of yesteryear, we were like, stop your drugs at all cost. God forbid you take drugs while you're pregnant because you'll explode, right? And we were wrong. Now, if you fast forward to circa 2016, we realized that it's safe to become pregnant on Tysabri. Like you can conceive while receiving Tysabri and it doesn't hurt the fetus. And in fact, you can stay on Tysabri for the first trimester and the second trimester before there's a concern to the baby. Taking Tysabri in the third trimester can cause anemia of the baby, which is not a goal. And so what we used to do back in like circa 2016 on is we would put someone who wants to become pregnant on Tysabri, tell them to have copious unprotected intercourse and get pregnant. And then they would gestate and carry the baby through the first and second trimester, then stop. They would go through the third trimester, deliver, breastfeed, then go back on Tysabri. And I have shepherded multiple families through pregnancies that way. So there was a paper done about a year ago or so by this big French group, and they looked at all the patients that got pregnant on Tysabri and all the patients that got pregnant on Ocrevus, and I'll explain how in a second. And what they found was fascinating. The Ocrevus patients, not a single one had attacks with what I'm about to share with you. But the Tysabri patients, the way that I described, there were several attacks. And so in this Pepsi Coke challenge, they demonstrated that Ocrevus is safer. Here's how they would recommend doing it. And this is now what I recommend in my clinic. Is you get on Ocrevus, you take Ocrevus for say like a year, and then you stop Ocrevus. And so you stop Ocrevus, let's say in January. 5 months later, there's no Ocrevus in your body. And so you start having unprotected intercourse with frequency. And then you do not get your next dose of Ocrevus when you would be scheduled to. But keep in mind, earlier we talked about the B cells don't come back right away. So you have copious intercourse and you get pregnant, and then you don't get more Ocrevus, and you gestate 9 months, no Ocrevus, you deliver the baby, you breastfeed. And in the French study, they breastfed on average for 6 months, so not a short period of time. And then they went on Ocrevus after they were done breastfeeding. And so they were off for about a year or a little more than a year, and not a single one of them had an attack because that B cell depletion doesn't come back right away. And so that's really cool. And it's a great option to know about. Now, going back to what we were saying, I do agree with your doctor that it's safer to try to do the Ocrevus route, but I have some patients that are on Tysabri, they don't want to come off, and we can still do the old way. It just might not work as well.
Thank you. Alicia wants to know who and why would someone not qualify for Botox in the muscle?
Um, so there's a couple different things. One is the insurance product. So it might have nothing to do with anything except the insurance doesn't want to pay for it, right? So that does happen sometimes, but I don't think that's what they're asking. So if Botox treats spasticity and dystonia, and so if you don't have spasticity or dystonia, then you wouldn't want to do it. And you can develop an allergy or an intolerance to Botox, in which case then it wouldn't be safe to give you any more. But that's kind of rare and doesn't happen very often, fortunately.
I'm a 50-year-old female diagnosed with last year with relapse remitting. My symptoms are mild, but many mirror
Menopause?
perimenopause, menopause, and I'm wondering what, if any, research is going on with hormones and MS. I've read research where midlife women with higher FSH and lower estrogen have greater brain white matter. Hyper intensities. Do we know if hormone levels affect MS?
Yes. So this is a very, very important topic. I actually made a YouTube video on the impact of menopause in MS just a couple months ago. So you can find that on my YouTube channel. When estrogen levels fall and progesterone levels fall and anti-Müllerian hormones fall, you can start to have irregular menstrual cycles. So instead of being like clockwork, it can start to become erratic. And then at some point, when they fall low enough, you stop having menstrual cycles. And when you haven't had a period for a year, we define that as menopause.
Mhm.
And in the setting of menopause, and this has been studied, and I would encourage you to look up an amazing MS neurologist named Riley Bouvet. So Dr. Bouvet has UCSF has done a lot of this research, and I love her work. She's fantastic. And so if I quote some of it, when you go through perimenopause or menopause, the attack rate does not go up. In fact, frequency of attacks might even go down a little bit, which is pretty cool. But progression of disability occurs faster. Women have a slower disease course than men until they reach menopause. At menopause, it speeds up and it becomes just as fast as that with men. And there's a lot of symptoms that can, as this woman pointed out, can occur in the setting of menopause, which make MS worse. So, for example, menopause by itself can cause cog fog, depression, and anxiety. Menopause by itself can cause poor sleep and insomnia and fatigue. Menopause by itself can cause difficulty with bladder function, bowel function, and difficulty in the bedroom. And all of those things can happen in the setting of MS. And so sometimes nature's a little too generous. What can you do about it? You can supplement estrogen. Now, let's talk about this for a second, because at least in the United States, obstetrician, gynecologists, it's fallen out of favor to give women estrogen or to give them hormone replacement therapy. And the reasons are very valid because if you give combination estrogen progesterone therapy, it can increase the risk of cancer, which is bad. But giving estrogen only therapy does not increase the risk of cancer to the same degree. So that's one piece of the puzzle. The second thing is that when you take oral estrogen by mouth, it increases the risk of blood clots, which is also bad for you. But topical estrogen does not seem to do that. So I am a big proponent of women impacted by MS who are in their, 40s, 50s, 60s, in that age range to talk to their gynecologist about getting on estrogen only topical replacement. And that can help a whole bunch. If we're dealing with the down there's, particularly in the bedroom, where you can have vaginal dryness, which is unpleasant, and dyspareunia, which is a word for sexual sensation freaking hurts, then a topical estrogen can be very, very helpful. And there are creams, and I met an OB-GYN and said, honey, just tell them to slather it on down there, which I thought was kind of funny. But that's exactly what she recommended doing. And so the topical estrogen will help increase blood flow and engorgement and lubrication and a bunch of really good things.
Thank you. And we have tons more questions, but I know you need to leave.
I
So
do.
can we do one more?
Yes, ma'am. Yep.
Okay. So, and I've never heard this one before, so we're going to go with is do you see that there's any correlation between, and I just lost it now, but anyway, between bariatric surgery and MS? Because they got one, I think it was in 2000. Again, there's so many here that I'm losing them
Yeah.
as they're popping in. I think it was
So
2 years apart, and so they're questioning.
So no known association between bariatric surgery and multiple sclerosis. What I will say is that oftentimes people impacted by MS are at risk of gaining weight because it can be harder to move around, right? And it slows down their metabolism. And so sometimes people impacted by MS can gain weight, and that really has a negative impact on their neurological status. And so fortunately, we have studied um, bariatric surgery in MS, and it's safe. So it's not dangerous for someone impacted by MS to have bariatric surgery. And it's very hard to lose 100 pounds when you can't walk. Like it's very, very challenging. And so nowadays, there are two tools that we can use. We can use the semaglutide injections, which can help facilitate weight loss. I still think the very best option is weight loss surgery. Absolutely. And so it's safe in the setting of MS, and I recommend it routinely for my patients that are struggling with weight loss.
Thank you. And that does bring us to the end of our time. If you've missed any part of this conference, it has been recorded, which will answer the question to all of you that were asking questions about, you wanted Dr. Boster to repeat things. And if you go back to this in a couple weeks, you'll be able to hear it all over again on YouTube or on Facebook. So, and it will be available through the MS Focus Facebook and YouTube channels. Reply to your registration email for information on how to access the recordings, or to even sign up for our newsletter to learn more about the upcoming events. Our next teleconference is going to be this next Monday, a week from today, August 26th, at 4:00 p.m. And Dr. Herb Karpatkin, who's a PT, will be presenting Ask the Physical Therapist, and he's also going to do an hour long of Q&A. As we leave the conference today, a survey will appear on your screen. We ask that you just take 2 seconds to fill that out. It's not a long one, because your suggestions on future topics, on what's important to you, is really what moves us to be able to make things that are most meaningful for you. So our sincere thanks to all of our attendees for your participation, and especially to Dr. Boster for his knowledge and, being able to just be the Energizer Bunny one after another. Didn't even come up for air. So we really appreciate your time and your effort, Dr. Boster. We love it. Have a
Well,
wonderful evening.
it's fun to be here. I love working with you guys, and I'd be happy to come back whenever you're ready to do it again.
Thank you. Have a wonderful evening, everyone, and we hope to see you again soon.